Thank you very much, Sean. Hello, everyone. Bear with me just a second while I share my screen. Okay, so I think we should be set. So like Sean said, my name is Jennifer Tinker. I'm one of the neuropsychologists here at Jefferson in neurology. I'm housed within the epilepsy division. And what that means is that I see a lot of epilepsy patients, many of whom have brain tumors, but really neuropsychologists see everything from ADHD to Alzheimer's. And so our job really is to know a lot about brain and behavior functioning and then figure out how to apply it to each presentation that comes to us. And so just to give you a sense of what today will look like, this is our roadmap. We'll very briefly talk about what survivorship looks like in brain tumor and what a neuropsychological evaluation even is. I'd like to spend some time essentially establishing some common vocabulary in terms of the brain and cognition, talk about what that specifically looks like in brain tumor survivorship, talk about what mental health and brain tumor survivorship looks like, and then most importantly, what can we do to improve mental health and what can we do to improve cognition? And some of that can come just from implementing some strategies that we could recommend here. Other things, sometimes more fine-tuned answers, sometimes have to be completed with a full neuropsychological evaluation. I already see some questions in the chat. Because I'm operating solo tonight, I will reserve all the questions for the end, but I will try to answer everybody's questions. So what is survivorship? Cancer survivorship focuses on the health and well-being of a person with cancer from the time of diagnosis all the way until the end of their life. Some people don't particularly like the term survivor, and that's okay. But really we use this as a common term that can be helpful in improving care, particularly from a research-driven perspective. But we recognize that that may not capture everyone's experience. When the term was first introduced, it really was related to caregivers, but the literature now kind of defines survivorship in these three stages. Acute survivorship is focused on cancer treatment initiated at diagnosis through the end of treatment. Extended survivorship occurs after the end of treatment and really focuses on the effects of treatment and follow-up care. And then permanent survivorship focusing on the years after cancer treatment has ended. So the reason I highlight this is that neuropsychology and neuropsychological evaluation can be indicated at any stage of survivorship. It really is based on the question that you are asking or that your treatment team is asking. So this is a very busy slide, but I think it's meant to highlight that we are incredibly complex people living in an incredibly complex world. And there are innumerable factors that contribute to any one person's experience. Our job really is to consider all of these things. We know that individual differences and characteristics weigh very heavily into a person's experience. And so everything from baseline fitness, financial status, level of support, medical comorbidities, all contribute to our experience of survivorship, mental health, and wellness. And so each of these factors on the right there that you see, these are things that can have a very measurable and synergistic impact on our cognition and mental health. And so those are always things that we're looking to evaluate. What we know about cancer survivors, is that one of the most prominent symptom clusters tends to be fatigue, cognitive impairment, and depression. They commonly co-occur, and each symptom can interact and magnify the others. So the approach for quality of life has to be multifaceted, and we want to address all the outcomes and all the symptoms so that we can achieve optimal outcomes. So similar to that last slide, there is no one pathway in terms of symptom expression or treatment. We know that mental health is not the only concern in survivorship. And in fact, the majority of patients, at least 75% of patients, have many symptoms. They tend to cluster together, but certainly brain tumor survivor patients often complain of all of these problems: hormonal changes, headache, personality changes, and even sensory and physical changes. Like I said, these things are pretty synergistic, and the things that impact mood and cognition in brain tumor patients generally come from three factors: neurobiological factors, psychosocial factors, and then iatrogenic or medication-related factors. So what we're doing to treat the cancer. And so when thinking about these key factors, those neurobiological factors are generally things like age, gender, type and stage of brain tumor, location of the lesion, treatment and disease progression. And so we know, for example, in children, that children older than age 3 tend to have higher survival rates than infants. Adults below the age of 45 tend to do better than older adults. We know that tumors that are slow growing generally have a better prognosis than aggressive tumors. And psychosocial factors are enormously important. And so this encompasses sort of who we are, where we live, and what we do. And so things like social support, interpersonal support, previous chronic illness, coping mechanisms, history of depression or anxiety, trauma history, community level adversity, resiliency, all of these factors contribute not only to our mental health during and after cancer treatment, but also into people's motivation. And personality factors like independence can affect a person's outlook on life, and that in turn can affect cognition. The reason that's important is that we know these psychosocial factors that can provoke things like depression and anxiety can interfere with memory, particularly memory, attention, and processing speed. And stress, whether it be good stress or bad stress, impacts cognition. And so, our job is to find the optimal level. Stress is essentially a bimodal distribution where high stress and low stress don't optimize performance. And so we want to optimize cognitive performance. And then, of course, treatment-related factors. And as neuropsychologists, we want to incorporate all of this into our assessment to determine what can be implemented to achieve the highest quality of life. I think the one thing that is not encapsulated in this is that beyond all of this is that, we all have these social determinants of health: where we live, how we have access to care. And, during COVID, I saw a really poignant painting that essentially summarized by saying, we all are in the same storm, but we have different boats. And so it's important to recognize what resources we come to the table with and how that might impact what people and your treatment team recommend for you. So, what is a neuropsychological evaluation? It is the gold standard for evaluating cognitive function, and it may be requested by a patient, a doctor, other professionals who are all trying to understand the different areas and systems of the brain, how they're working and how they're working together. So I often tell patients, just like an MRI is a picture of the structure of your brain, neuropsych is a picture of the function of your brain. And so it's typically a long endeavor. It's usually the whole day. And that looks like sitting down with us, sitting down with your provider and talking about your life history. We really start from birth to the day we meet you, and we get a really holistic picture of who you are, where you've been, and where you want to go. And then the remainder of the day, based on the questions that come from that conversation, is spent completing neuropsychological tests with the technician typically. And we measure all sorts of cognitive skills, things like memory and attention, processing speed. We also ask about your mood and personality, particularly in cases where people have had a personality change. We might have observers or a loved one also fill out similar questionnaires, asking about your current mood and personality, your previous mood and personality, so that we can document and objectively determine if there's been a change, if that change is likely to persist. And so once somebody goes through a neuropsych appointment, they spend the day with us, and then several weeks later, they come back either in person or via telemedicine nowadays, and we talk about the results. And we'll talk about how you did on testing, diagnostic impressions if there are any, and then most importantly, I think what our recommendations are based on your unique brain profile. And that can vary wildly depending on the outcome of the results. I think one thing that's important to recognize is that these are objective, valid, and reliable. And the performance-based measures, it's all paper and pencil, there's nothing invasive, but that we not only compare you to a normative sample based on certain demographics, usually age or education, but also to your own pre-morbid benchmark. So what that means is, you know, at the best day of your cognitive functioning, where your IQ and your cognitive functioning look like compared to now, there are certain hold measures that we know don't change sort of regardless of brain insult. And so that helps give us insight into your personality and your cognition, because we know particularly people who are high functioning and have traditionally done very well academically or vocationally, sometimes question whether or not we have a good baseline of comparison. And we're not only comparing you to people that have similar education and background, but also to your best self. So this is what it will look like to a bit. That these are a few of our tests measuring visuospatial skills. Sometimes we ask you to integrate a 3D block model to look like a 2D presentation. We'll play a connect the dots game that measures processing speed. That connects the dots game sometimes gets more complicated by asking you to switch back and forth. And really, just like I said, each part of the brain controls different functions, and our job is to assess each of those areas of the brain and the domain that is controlled by that area, so that we get a really good picture of accurate and current brain functioning. So why go through this? I think, you know, it documents the course of a brain disorder. It tells you about your current cognitive functioning. And from my perspective, the identification of treatment needs. What are we going to do to optimize quality of life? Is there a medication that may be affecting cognition? What is the result of surgery? How did surgery impact cognition? What's the likely trajectory of recovery for that surgery? And then answer bigger life questions. Is a return to school possible? Is a return to work possible? Sometimes we repeat neuropsychological testing over time, particularly in our epilepsy population. We see people many times over their life. Sometimes if surgery is considered an option for your brain tumor, we might see you before surgery and after surgery to guide treatment. Sometimes people can have personality changes as a result of treatment or as a result of surgery, and taking a deeper look at personality and cognitive functioning can help us predict prognosis, but also help manage behavioral changes in the moment. I would be remiss if I didn't acknowledge that there are some limitations to neuropsych assessment. And, you know, ecological validity is the greatest limitation. Sometimes people can function much better in the real world than they can in our testing environment. Sometimes people function really well in our testing environment, but when they face the real world, the environmental distractors are such that they don't perform optimally. And so cognitive testing that we do typically gives us your best and most optimal cognitive functioning in this very controlled environment. That's not always the case in the real world. As our country and our world becomes more multilingual and multicultural, neuropsychology is facing challenges in measuring tests that are normed appropriately for different languages. We can do testing in different languages. We can do testing with interpreters, but the interpretation is not as convincing depending on what norms are available. It is a long process. I think it's generally an interesting day, but I'm very biased. I think it can be frustrating, particularly because we don't give easy tests. if we give easy tests, we don't learn very much about your brain. And so most of these tests are built so that if you do something well, we make it more challenging. And if you do that well, we make it more challenging. And so you're always bumping up against your frustration point, which from our perspective is really fantastic because that tells us your capacity, but it can be a frustrating day. I think we're pretty good at mitigating that, but it's definitely a commitment and you have to be willing to take the ride. So these are the common cognitive concerns we get very commonly. I always say that everybody comes to the neuropsychologist complaining of a memory problem, but that can come from a lot of different places. And so walking into a room and forgetting what you wanted, forgetting people's names, not thinking of the right word, forgetting things your husband tells you, all of those things likely come from a different brain region. And so if you walk into a room and forget what you went to get, that's likely an attention issue. Forgetting people's names could be a language issue. Finding the right word is certainly a language issue. And then sometimes when truly forgetting things that is not recoverable with cueing, then that gives us more concern about a memory problem. So when we're talking about cognition, it can be helpful to have a common vocabulary. And I am certainly a child of the 80s when the food pyramid came out. So I think I tend to think of cognitive functioning as pretty hierarchically organized. And so you'll see here, attention and concentration are certainly the fundamental building blocks of cognition. If you don't pay attention to something, there's no way you'll encode it and remember it later. And so that's the first thing we measure, and then that really influences all other levels of cognition. Most of our cortical skills, things like language and our visuospatial abilities, our ability to navigate problems, navigate through Philadelphia, those are cortical skills that are important. Learning and memory is really temporally driven. We'll talk about that in a second, but that is typically what people come and tell us the problem is. And so we really investigate learning and memory, but the learning and memory problems can happen for a lot of reasons. And so one of the primary reasons people have cognitive problems is something called executive functioning. And executive functioning really is what makes us human. It's our ability to engage and disengage, to track things over time, to multitask, to problem solve and organize. And all of these things are at risk depending on the type of brain tumor and type of treatment. And so we really have to have a good picture of each and every one of these to understand what's going on for an individual. So we won't go too deeply into neuroanatomy, but if you learn anything from this slide, I think the important thing is that different areas of the brain have different jobs. And so, like I said, those executive functions are predominantly driven by the frontal lobe. That also controls motor skills and planning, speech production. The temporal lobe is primarily responsible for memory, many aspects of language. The back part of our brain here, the pink part, the occipital lobe, it controls vision and vision perception. But that parietal lobe often causes problems too in terms of attention and orientation and spatial planning. And so our job with a neuropsychological evaluation is essentially to map functions onto the brain, see if it correlates with the known lesion or the area of disruption, and help guide treatment. So I won't delve on this very long, but in terms of human memory, memory is stored in different areas in the brain. And when we talk about memory in popular culture and from a layperson perspective, really what we're talking about is that episodic memory of events, forgetting what happened yesterday, forgetting details of a movie. That's all declarative and explicit memory. And that's stored in a very different place than things like procedural memory, learning to ride a bike, learning how to type, learning your shower routine. All of those things are a different form of non-declarative memory. And those things don't typically change with any cognitive insult. And so most of what we talk about is really episodic memory. And the reason that's important is that episodic memory starts with encoding or learning something. Then you have to store that information, and then you sort of have to quickly go retrieve that information. And if we interfere at any one of those points in memory, that's when problems arise, typically what we hear as memory problems. And so just to give you an example, if someone has a learning disability, they might have trouble encoding information. If they have trouble learning new information, then the ability to store and retrieve later will be interfered upon. If someone, for example, has Alzheimer's disease, it's really a storage problem. And so we think of that sort of like a bottomless bucket. Information goes in normally, but then the neuroanatomical structures that are responsible for memory storage fail, and that information just sinks and it's gone forever. What we most commonly see in most brain tumors is a retrieval problem. And so something like a junk drawer problem. The information is there, but because of the disruption of networks, either in the cortex because of medication or a resection, it's hard to go get that information. Ultimately, that is a good prognostic sign because there's ways we can build scaffolding to build or cue you to find that information, even if information is not as fluidly accessible as it once was. So I think, not surprisingly, deficits in neurocognitive functioning in brain tumor patients is very common. It occurs across different types of tumors, both primary brain tumor and metastatic disease. And I think based on what I've said so far, I hope that the message has come through that each person's cognitive functioning relies almost entirely upon their unique set of circumstances. The mechanisms for cognitive dysfunction are several. Tumor-related factors can include direct tissue damage due to cell death, compression of the brain due to mass effect, edema or swelling, infiltrative growth. And so all of those things can look different and can affect different things. There's also individual differences. Older age is typically associated with higher risk of cognitive dysfunction. Cognitive reserve is this concept essentially that it's what we develop throughout our life in terms of education, work, our curiosity, our ability to learn new things. Essentially, the more you challenge or push your brain throughout your life, the greater cognitive reserve you have. And that can be protective in the case of cognitive insult. Medical comorbidities, things like cerebrovascular disease, sleep apnea, organ disease, things like kidney or heart disease, liver disease, all can individually contribute to cognitive problems. And as we accumulate cognitive risk factors, declines can be more significant. Generally, the pattern of cognitive dysfunction corresponds to the brain areas affected by the tumor. So for example, there's an area of the brain called Broca's areas that's responsible for language. And if that is affected by tumor, then you might have an expressive aphasia, difficulty expressing yourself through language. We do know that more aggressive tumor growth can interfere with neuroplasticity. That's the brain's ability to regenerate, grow, and reorganize in the face of insult. There are multiple neurosurgical interventions possible in tumor. And in fact, some neurosurgical interventions can alleviate symptoms, particularly if there's mass effect, but can also cause cognitive dysfunction if a critical region of the brain or critical pathway has been damaged. Currently, we typically use something called functional MRI or brain mapping. So functional MRI is the same as an MRI, but instead of resting and ignoring the loud noises, you're asked to do tasks. And that what we find is what brain regions are active when you're doing certain things. That can help guide brain surgery, as can brain mapping during surgery, where we use electrical stimulation to stimulate different areas of the brain to identify eloquent cortex and then protect it if possible. The greatest risk of post-surgical decline is for people with high baseline functioning, particularly those in language and memory, and people who have a dominant hemisphere resection, which means that your dominant hand is controlled by that hemisphere. Typically, it's the left hemisphere that controls language for right-handers, and that hemisphere becomes dominant, or frontal or temporal resections. Chemotherapy, there's an extensive literature on chemobrain. It's beyond the scopes of this talk, but the cognitive effects of chemotherapy can be seen acutely and are significant in a minority of patients with primary brain tumors. It tends to affect things like attention and cognitive processing speed, things we associate with subcortical regions of the brain. Chemobrain does tend to resolve over time, but not always. There's some literature in the lymphoma world that suggests that there is persistent chemotherapy impact. Radiation can have acute, early, and delayed long-term effects on cognition, each due to a different mechanism of injury. And what we see here is that typically radiation in the acute phase may cause some fatigue, nausea, and vomiting. But really, the most concerning cognitive problems come from delayed radiation effects. And the image on the right is radiation leukoencephalopathy, essentially cell death of the white matter within the brain. So as neuropsychologists, we are psychologists first, and mental health is primary to what we do. Depression, anxiety, and distress are very common in people with cancer. About a third of patients with primary brain tumors develop clinical depression or anxiety at some point. 3 out of 4 patients with primary brain tumors experience psychological distress. Obviously, this is a life-threatening event, and it sort of sets off a bomb in your life, and it doesn't only affect you, it affects your whole family. And so a high level of distress is normal. When it becomes debilitating and interferes with your everyday life, that's when we recommend treatment that can reduce symptoms. Tumor or cancer recurrence worry is normal. Only when it becomes debilitating would we treat it. There is treatment that can reduce the severity of those fears and stop them from interfering daily life. I would implore you, don't sweep your distress under the rug. Tell your treatment team if you're feeling stressed or overwhelmed. Sometimes you have to ask for help. It's not always obvious to your team. And you know, when asking for help, there are many resources available, which is what we're going to spend the rest of the time talking about. So what you can do is those things that we know that are good for us. Find social support, engage in meditation or yoga, exercise, good nutrition. But your provider can also identify medical conditions that might be contributing to mental health challenges. That includes medications that can sometimes contribute to mood disruption, and refer you to specialists, whether that's a social worker, a therapist, a religious leader. You know, this is a collaborative endeavor, and we're very comfortable meeting people where they are. I have lots of patients who really are uncomfortable with the idea of psychotherapy, but have a religious community, and we can find specific religious leaders or people who operate from a religious perspective. Jefferson has a ton of community-based, Jefferson-based supports that I won't review here, but both the Jefferson Cancer Support and Welcome Center at the Hopkins Center and the new Center for Supportive Medicine and Cancer Survivorship offer holistic care that includes things like mental health assistance. one thing I will say is that what's good for your body is good for your brain and good for your mood. And so you are probably sick of people telling you that exercise and nutrition are important, but there are known benefits to specific cognitive domains, things like attention and memory, with exercise and yoga and meditation. So when those available supports are not enough, your provider can refer you to a psychiatry or a psychologist. Medication can be helpful and is generally effective in mild depression. About half of the people who have mild depression respond to medication alone. But the gold standard for treatment of depression or anxiety is definitely a combination of medication and psychotherapy. I often use this analogy with patients that if you're drowning, medication can serve as a life preserver to keep you afloat, and then therapy is what teaches you to swim ashore. We typically recommend a form of therapy called cognitive behavioral therapy. It's time limited, goal oriented. Hold on there. Time limited, goal oriented, and problem focused. So this is not lying on the couch and talking about your childhood. It's really about what is your problem in life right now and what we can do to fix it. It's usually two-pronged. One is behavioral activation. That's examining your daily routine, make sure you have an adequate structure and a daily sense of accomplishment and a daily sense of pleasure, two things that protect us from depression. The second piece is examining the automatic thoughts that pop in our head all day long. Those thoughts, while helpful from a heuristic perspective, because our brain has a lot to do every day, aren't always accurate. And so it can be helpful to learn strategies and tools to examine whether the thoughts that pop into our head are valid. And so, the things that we tell ourselves affect our emotions and our behavior. And we, as a product of being human, often make cognitive errors that contribute to our distress. And so the way you think, feel, and behave are connected. And if we change any one of those three, we can change the others. I often give the example, if I saw Dr. Evans in the hallway and said hello and he didn't say hello back, what I think about that interaction will affect how I feel. So if I think to myself, oh, he must be really busy, that probably won't affect my thoughts about myself. If my automatic thought is, oh, he doesn't like me, that can really start a cascade of negative thoughts. And so really looking at and examining those thoughts for their validity and their adaptiveness. Other types of therapy include acceptance and commitment-based therapy, which instead of essentially encourages patients to stop avoiding inner emotions and instead embrace them and accept them in a way that would not prevent them from moving forward. Mindfulness is based on the concept of mindful meditation, a non-judgmental, present-centered awareness in which each thought, feeling, or sensation that arises is acknowledged and accepted as is. There's tons of relaxation training options. This can be particularly helpful in anxiety. I won't go through all of those exercises here, but essentially the nervous system has a sympathetic nervous system that drives our fight or flight response and a parasympathetic nervous system that is our rest or digest system. And unfortunately, the sympathetic nervous system works fast, the parasympathetic nervous system works slow. And so really bolstering that nervous system through different mechanisms, either through deep breathing or muscle relaxation or sensory grounding, can help instill a sense of calm and really build that over time to prevent distress in the face of stressors. So let's talk about addressing our cognitive concerns. One thing that's important to recognize, memory problems are normal. Everybody makes cognitive errors every day, and there's a certain number of those that are normal, particularly as we age. And so what is normal to remember at 20 is different than what's normal to remember at 40, which is different than to remember at 60 and 80. And so part of the natural aging process is a loss of memory. And what comes, the counter to that is hopefully wisdom. The rest of our cognitive skills are more resilient. And so by relying upon our problem solving skills and our knowledge, we can make memory changes less impactful. There are lots of things that you can do that affect your memory and are in your control. So taking your medication, treating mood disruption, reducing your stress, meditating daily, getting good sleep, minimizing alcohol intake, and engaging in life. Social activity, physical activity, and cognitive activity are all important for healthy aging. And so if you can do one of those things every day, you're doing what you can for your brain. There are some medications that can help with cognition. We have some medications that are attention enhancing agents, some that are cognitive enhancing agents or wakefulness promoting agents. There are small studies in the brain tumor literature to suggest that some medications might reduce radiation toxicity. Typically what we are doing though, and from a medication perspective, is off-label and informed by the neuropsych evaluation. So we all could use a little scaffolding, and most of these things feel like common sense, but they are also things we constantly ignore. And so repetition, structure, and routine are the best friend to your memory. I often tell people to have a memory bowl sitting at their back door or front door, wherever they exit. And that's where your keys go, your wallet, your eyeglasses, everything that you need consistently. If you get into that routine, then it's likely that that will always be there when you're looking for it. Now, there's also, well, we'll get to the apps in a minute, but I think, making lists, keeping calendars, summarizing or repeating back important information on a phone call when you're reading to really and help encode that information. If you hear it once, you might remember it. If you hear it twice, you're more likely to remember it. So if you hear it 5 times, your memory system has really gotten the message and you have a better chance of encoding it. We also want to incorporate our whole brain. And so the dominant hemisphere of our brain, typically the left hemisphere, is responsible for verbal memory. The non-dominant hemisphere is responsible for visual memory. And so if you're having trouble remembering things that are said to you, condense it into pictures. If you're having trouble remembering what you see, say it out loud. We really want to recruit both sides of the brain to remember as much as we can. We'll talk a little bit more about mnemonic strategies, but many of us are familiar with those. Make something a song to remember it. Use acronyms. I'm sure everybody on this call knows what Roy G. Biv means, or please excuse dear Aunt Sally. If you need 5 things from the grocery store, figure out if it spells out a word. The first letter of each thing spells out a word. And most importantly, in our technologically advanced world, there's an app for that. My phone remembers where I parked my car, can track where my kids are, reminds me to take medicines, schedules appointments, reminders I may need. And so I really encourage everybody to use Siri or Alexa or Google Home. Use what is available to us to your advantage to build that external scaffolding to support memory. When that's not enough, we have a continuum of care for rehab. Oftentimes, speech therapy and occupational therapy are recommended in the short term, but there are also specialists focusing exclusively on cognitive rehabilitation. And so that usually involves learning compensatory strategies, using or training with assistive devices that support cognitive function, and sometimes remediation, like cognitive training or exercises to improve skills. There is a growing literature supporting the efficacy of cog rehab in acute and post-acute settings with good outcomes for primary and metastatic brain tumor. the only caution that I will leave you with is that most of the computer interventions and phone apps that are marketed to us do not have good evidence behind them. And so there's one program that we know has any good data behind it. Otherwise, I think I would definitely spend your time and money working with a professional to learn skills that you can implement in life. And there are growing programs for cog rehab. The epilepsy world has a huge self-management program for epilepsy. And one of those things is a cog rehab program that is totally free to patients. And I am sure within a year to two that will be available in a range of diagnostic indications. So we've talked about these external memory strategies and these internal memory strategies. You know, build as much scaffolding as you can around yourself, keep a calendar for appointments, make lists, but also when you know you have to remember something, do so with a strategy. If you're having trouble finding the right word, if you can't talk around it, try to think about things in that category. So if you're thinking of the name of a German Shepherd, but you can't come up with it, start listing dogs. That will activate the neural networks that store the semantic meaning of dogs. And that sometimes can get us to where we are. Like I said, we want to recruit the left and right hemisphere of your brain. A picture's worth 1,000 words, and visual imagers can hold large amounts of information. And so if we make use of that skill with specific visualization techniques, that can sometimes help support memory. Or else use our other hemisphere to compensate for weaknesses. One thing we often teach people is something called a memory palace. It's a memory technique that associates items or topics with locations within a room. And so this room is here just for our purposes. You would want to use a room that you're quite familiar with. So your living room, your first floor of your home, and you can build it in several ways. You know, decide where you're going to put the banana, the chocolate, the milk, and visualize yourself walking through your home, seeing those three things. When you get to the grocery store, the likelihood that you'll remember those things is higher. So there are tons of references and resources available, both through Jefferson and on the internet. My email is listed here as well, in case we don't get to all of the questions. And at this point, I will pause and take questions. Let's see.
Dr. Tinker was, will slides be available to be sent out via email?
Yes, we can. I'm pretty sure that can happen.
Yeah, if you're willing to, you can send them to me, and I'll send them out through the inbox that I have set up for the webinars.
Yeah, absolutely. So yeah,
Okay.
we'll share those.
Awesome.
So I see a question here. What resources are available in mental health support services for survivors? So I think there is, there's a breadth of available resources, both through Jefferson and through national organizations that are included here. Another question here, are there data or assessments showing what resources are lacking in post-cancer treatment, specifically in financial and mental health services, management of comorbid conditions, and preventative care? So I have to say, I don't know the answer to that question, but I think that the investigations that have been most fruitful in the past several years is how the social determinants of health impact post-treatment life. And so there are huge financial burdens, and access to quality care is absolutely underrepresented in certain communities. And so there is a good amount of data examining where those deficiencies are. I don't know that there's a ton of good data on progress as it stands, but I may not be the best person to answer that question. This is a question that says, I was interested if the issues related to brain tumor patients are temporary or permanent, mainly pertaining to personality changes. And that's a really good question. And I think, unfortunately, it depends on a person's unique situation. I think there are clear personality related changes related to tumor and tumor growth that can change with resection or treatment. And so that would be fluid based on treatment and tumor reduction. There are also more permanent impact of resective surgeries, for example. And so it really depends what is contributing to the personality change. So, for example, oftentimes we will see personality changes related to medicine that resolve when medications are removed. People with personality changes related to frontal lobe involvement tend not to resolve completely, but depending on the nature and course of the brain tumor, there can be neuroplasticity such that other areas of the brain accommodate, or people accommodate to this change in their personality or sense of self. And so there is absolutely change over time. It just depends. Let's see. Is there a correlation with the type of brain tumor with psychological consequences? So I think the better answer for that is that the severity of brain tumor is associated with severity of psychological consequences. Brain tumors in the frontal lobes are particularly vulnerable to mental health changes, but by type, certainly meningiomas and low-grade gliomas are less concerning than more aggressive tumors. So someone's asking about cancer-related brain tumors versus all tumor types. And so all tumors can cause cognitive and mental health changes, absolutely. How does one know how long to allow for recovery from multiple surgeries and radiation for a large meningioma encircling the left optic nerve? I've done speech therapy, but several months later, I'm still not where I was prior to the initial surgery. How long does it take for cognitive functioning to return? And it sounds like maybe a provider said they weren't sure. And so what we know about brain recovery, depending on your age, the younger the better, but after surgery, there's usually a window of the first year where we would expect a progressive recovery. And so what we see in the first 6 months is a pretty sharp trajectory of recovery, followed by the next 6 months, generally, of a more protracted recovery. And so oftentimes we will see somebody maybe 1 month after surgery to get a good roadmap of what's happening right now. What are the problems that we're seeing post-acutely? Because those are the things that we really want to target in terms of treatment. And then over the course of the year, they engage in those treatments. Usually we see people at about 1 year following surgery. And when we do neurocognitive testing for those patients, then we're talking about something that might have more permanence. Now, that's not to say that people don't recover over time. There's good evidence of recovery for years, but the greatest trajectory and the steepest rate of recovery is certainly in the first 6 months, and then it slowly tapers and then ultimately plateaus. And so what I would say is that if it's been less than a year and you're still noticing expressive language problems that you are working on in speech therapy and you're not where you want to be, then I would advocate for yourself for more speech therapy or a different type of cognitive rehabilitation. And that's something that we do all the time as neuropsychologists. And we really push the idea that we want people to be engaged for at least a year in the continuum of rehabilitative therapies. That is totally counter to what our insurance companies want, but I think what is in the best interest of the patients is consistent recovery interventions for at least a year. And the other thing about this is that, you know, we are adaptable as human beings. And so you may grow accustomed to this change and find that you're living your life and things are great until you change jobs or you have a new responsibility that you just can't quite wrap your head around. Any of those times is a really good opportunity for cog rehab. All of these are very problem solving focused. And so cog rehab really is, this is the problem. You have essentially a coach that partners with you to figure out how to solve the problem. I see a question here. My question is, if a tumor tests positive for progesterone receptor, how does that impact the neurotransmitters? Also, what type of effects or symptoms can that cause a person? I don't know the answer to that off the top of my head, but I will get that answer. And so my email is listed there. If you send me an email, I will send you the answer back. The second question, how do you typically figure out if a tumor is causing a personality or change or anxiety in a person rather than being understandably anxious from having a tumor and that experience changing them? So I think both are true. I mean, this is a life event that alters people's lives for the remainder of their life. And so, you know, anything that is life-threatening causes a change in the trajectory of our life. But there are objective measures when we talk about things like anxiety, mood, depression, personality that tell us whether or not this is sort of a reactive depression or anxiety, which is not a clinical disorder. You know, there's adjustment disorders when people are actively struggling to deal with these challenges, but it does not qualify as a clinical depression or anxiety if it's appropriate to the situation. And so we do that through a number of objective tests. So I think that is the last question. So unless anybody else has another question, I'm going to copy down this one question so that I can send somebody an answer if they reach out. But otherwise, thank you very much for your time.